So it is my pleasure to welcome our next speaker, who will be speaking about yoga and fibromyalgia, Dr. Mandvi Tandon. So the floor is yours.
Thank you. Thank you for everyone being here today. Thank you, Lori, for that great introduction. I usually like to start off with, I pray to the divinity within all of you. Thank you for showing up. Thank you for the support, the love. It was unfortunate that I was not able to be here in person yesterday, but I am just as much excited to hear all of your presentations, and I will be listening to them through the video assignment, so I'm looking forward to hearing yours. Before I begin, I know, Lori, we just grounded ourselves through a brief meditation, but the topic of discussion is management of fibromyalgia, and in that there is a little bit of practicum that is integrated. So if you don't mind zoning back into your Zen state, stay seated as you are, or if you need to realign or readjust yourself, please do that. And this is just take 5 breaths from your belly, so you're activating your lower belly. As you inhale, the belly comes out. As you exhale, the belly comes in. Keeping your head, neck, and trunk in alignment. And just notice the pattern of your breath. Is the breath equal? Is the breath continuous? Is the breath deep? Are there any jerks? So smoothing out that breath, that continuous breath. Deep, long inhales, deep, long exhales. And it's okay if the mind is wandering. Just simply bring your awareness back to your breath again. And allow the mind to just rest in that breath. And acknowledging the divine that resides within you. And then as you're ready, you begin to wiggle your fingers, your toes, coming back to your surroundings, and gently opening your eyes. Thank you. So the topic of discussion, which you've all been waiting for, is management of fibromyalgia through the lens of integrative medicine. Swami Rama, the founder of the Himalayan Institute, says, all of the body is in the mind, but all of the mind is not in the body. I'll let you think about that for a second. And hopefully, by the end of the presentation, you'll get what this quote is trying to say, or what this message is. I'm not going to explain it. Hopefully, at the end of it, you'll get your answer. Okay, so the agenda for today is everything, because it's integrative, everything is weaved in. So we're going to talk about my 2 case studies. And I'm not going to give you the treatment because it's all part of the integration. We're going to talk about the epidemiology, the clinical features of how do you diagnose fibromyalgia, the pathophysiology from the Western perspective, the pathophysiology from the Eastern perspective, and then how would you manage this from both the West and the East, And then what does integrative medicine say? Okay. Oh, I'm okay with questions in between, so if there is a concept that you need clarification on, go ahead and ask. So a 45-year-old homeless female presents with fatigue, generalized pain all over, anxiety and severe depression with a history of Lyme disease and a motor vehicle accident that happened 6 years ago. Through the yoga therapy assessment, remember that we do the kosha assessment and the dosha assessment. So based on the doshas, she had an increased vata, increased pitta, but she had a low digestive pittic fire. So the reason why I point that out is because the fire or the agni can be of 3 different types. One could be the body constitution, which is the pitta, and then the digestive fire can actually be, let me just rephrase that, can be of 3 different types. So we tend to group agni as just pitta, but it's not just pitta because there's 3 different components to the agni or the fire. So it's important because we would think that because she has increased pitta, we would assume that she would also have an increased digestive fire, which is the opposite in this case. And she also had decreased kapha. Okay. Then in the kosha model, her anamaya was she was in a lot of pain. She had a lot of heightened sensitivity to touch, which aggravated her pain. The pain was worse during mornings and would get better throughout the day. Relief was found in stretching exercises, and she figured out that by altering her diet, that would also diminish her pain. So she had done, prior to coming to me, she had done a juice cleanse, she had tried raw vegan diet to avoid also lactose, and she was aware that she had gluten sensitivity. So the pain started decreasing when I started working with her. At the beginning of the initial encounter with her, her pain was at close to around anywhere between an 8 to a 10. That was the range. And after each session, after each session, the pain would come down to a 0 to a 2. And after, she was my one client that I had for 16 consecutive weeks. So after the 16th week, she was very happy to say that it was close to a 0, maybe a 1. She was a thin build, yet she was athletic in her previous life, so she used to be a gymnast. She had a lot of muscular memory. She had very poor core strength though, and how I assessed that was through the tabletop. And that's how I also assessed, and I also assessed her agni based on the history that she had given me that she wasn't eating properly. Her in the pranamaya kosha, she was extremely anxious. She actually had a panic attack on the very first session with me, and she had a lot of, and she was a shallow chest breather. In the Manamaya, she had depressed mood. She actually had suicidal ideations as well. She had very poor self-esteem. And in the Vijnanamaya, she was actually aware of what was triggering her pain. She knew that the diet, if she altered her diet, it would affect her mood. So it would actually make her mood better. So she was pretty aware of that. And in the Anandamaya, I want to point out that this patient is homeless, right? So being homeless and still having this Vijnanamaya and also having the Anandamaya, you wouldn't correlate those two right away together. So the Anandamaya, she was actually extremely motivated, and I think that was the reason why she adhered to the entire 16 weeks with me, because it was her drive, her motivation for self-care and wanted to get better. Okay. So another case, a 60-year-old female on disability presents with fatigue, neck stiffness, generalized pain, and tenderness all over. Sleep disturbances, she had difficulty getting to bed and staying asleep. She had depression, migraine headaches. She also had TMJ dysfunction, and she was sexually abused as a child by her father. In the yoga therapy assessment, the dosha assessment, she had an increase in vata, she had decreased pitta, and she also had a decrease in the digestive fire. And so unlike that first client where it was increased pitta, this is decreased pitta. And she also had decreased kapha. Okay. Then in the Panchamaya Kosha model, the Annamaya, she was in a lot of pain. It was exaggerated sensitivity to touch. I would say this patient had more heightened sensitivity to touch than the first client that I had. She again also had poor core strength. She also had an anterior neck carriage. She had a posterior pelvic tilt. And in the Pranamaya, she was a reverse chest breather. So unlike the first client, she just was not breathing correctly. She was breathing from her chest. So, and in this case, she was reverse breathing. Does everyone know what a reverse? Yeah. Okay. And in the Manamaya, she had depressed mood and anxiety and extremely low core self-esteem. In the Vijnanamaya, unlike client number 1, she was actually unaware of what triggered her pain and what triggered her mood changes. Okay, but in her Anandamaya, she was actually motivated for self-care. She was another client that adhered to the entire session, so she stuck with me for the full 8 weeks. And again, this was the underlying reason, the motivation for self-care. All right, okay, so now let's look at how fibromyalgia is actually defined from a Western perspective. Approximately 1.5 billion people, that's a lot, all over the world have this diagnosis, have this condition. And approximately 5 million Americans have this, 5 million American adults. That makes up about 2 to 5% of the US population. And 90% of them are females, between the ages of 20 to 65. Okay, so client number 1, 45. Client number 2, 60. Okay, and the cost of care in treating these patients is through the roof. Over $13 billion are being spent on treating these patients. 3 times the higher the cost on these patients with the same age and same gender. Makes up 15%, about 15% of them go on disability. Okay, 3 top reasons why they go on disability, or they'll take more sick leave because they're in chronic pain, they have premature retirements, or they actually go on disability. Okay. So, a couple of things. Harrison, which is our internal medicine textbook, this is known as our Bible, defines fibromyalgia in 3 different categories. So they have risk factors, they have a genetic component, and they have environmental factors. And I want you to just follow me for a second, because you're going to start putting the pieces together. They have poor functional status. So poor functional status would be something like they can't balance a checkbook, they can't pay off their credit cards, they can't do day-to-day cognitive tasks. That would be a poor functional status. Female gender, client number 1, client number 2. Negative stressful life event. Okay, first one had a MVA, motor vehicle accident. Second one she was abused as a child. Low socioeconomic status. I mean, this is something that I didn't delve into with my patients, but my first client, if you remember, was homeless. Genetics, it's a polygenic inheritance, meaning that, you know how our phenotypes, are you aware of how genotypes and phenotypes work, right? So I am getting one nod. Okay, all right.
I'm going to say assume no.
Okay,
Assume no, that there's at least one person who won't say I don't know.
okay.
So yeah.
Okay, so phenotypes, basically the way they work is when you have many different genes that express themselves, right? On like our hair, the tone of our skin, the way we smile, everything is, these are all phenotypic expressions. Like even though everything is genetically passed on, but it's a number of different genes that crossed over to express themselves. This is what this is, polygenics. If we were to use that same analogy of phenotype, it's the same analogy as that's what polygenic means. It's a bunch of genes that was passed on from the family, from the family pool, that express themselves, and it's 8.5, it inherits likely 8.5 times for a first degree relative. So there is what this is basically saying, there is a genetic component to it. Okay, so then it's also seen with comorbid conditions, anxiety, depression, any mood disorder. So both my clients had depression. First client also had anxiety. They also coexist with autoimmune disorders. Okay, so there's research that's been done on this that 62% of fibromyalgia patients actually have a diagnosis of Hashimoto's thyroiditis. And because these patients have Hashimoto's thyroiditis, they also have IBS. Okay. And in the environmental, so physical trauma or injury, again, going back to client number 2 and 1, stressors, life event or abuse, both. Certain infections like Lyme disease and hepatitis C. I don't know if you caught that. Client number 1 had Lyme disease. Okay. So, this is taken straight out of Harrison. By the way, how do you diagnose fibromyalgia? I just described, these are the clinical, these are the risk factors. So prior to, I want to say prior to 2010, okay, I don't remember the exact date, but prior to 2010, there, the rheumatology guidelines, the American Rheumatology guidelines stated that in order for these patients to be diagnosed, they had to meet 11 out of 18 tender points, right? Tender joint points. They had to meet them in order for them to be diagnosed. They had to meet 11 out of the 18 criteria. Well, 2010 came, and that guidelines got obsolete. Okay? So they made it very, very simple. Basically, you draw a longitudinal line through your body, split your body in 1/2, right? And then you transversely split your body in 1/2. So you're divided up into 4 different quadrants. Now, based on these 4 different quadrants, if you have pain in like 3 different areas, and also you have any of the cognitive or the coexisting or coexisting and comorbid conditions for at least 3 months, then you have fibromyalgia. Not you. Patient has fibromyalgia, which seems a lot simpler than having them assess, does this hurt, does that hurt, each tender point. Okay, so a couple of things I just wanted to point out. So remember the migraine headache. My second client had this affective disorder, which was my client number 1 and 2. Client number 1 had TMJ dysfunction. I didn't find the IBS. Although I speculated my client number 1 had IBS because she was extremely aware of what was causing the pain. And that's why she had altered her diet. And then constitutional, they had definitely, both of them had sleep disturbances. One slept a lot. The other one just could not fall asleep and couldn't stay asleep. Okay, cognitive difficulties, let's see.
How many did you say they had to have of those? 3 of those?
3 out of 4.
At least
3.
No, 3 out of 4 of the quadrants, but of these comorbidities, how many do they have to have?
It didn't say, just,
At least one, so or just
Yeah, at
one?
least
That's
one,
not
yeah.
very many. Ah,
Yeah.
okay.
okay. All right, so that's how you diagnose and diagnose for fibromyalgia. So let's look at the pathophysiology, what's actually going on behind the scenes of why this is, I'm going to have to jump over here because I'm going to have to play a video. So there is 2 things that are happening, right? There is this dysfunction in the HPA axis. I'm not going to get into it because I believe Debbie talked about this yesterday, so I'm going to save my time. And then this abnormal pain processing in the CNS, also known as central pain sensitization. So I'm going to give you just a little background. When I studied medicine, we didn't know about this central pain sensitization, and quite honestly, most Western doctors don't know about this. So it had nothing to do with me like studying in India, or because I studied allopathic medicine. Most Western practitioners don't know about this. It's usually, how you know is if you are in pain management, you are an anesthesiologist, or you're working directly with pain patients, right? I'm going to get into how the pain, did anyone talk about the pain pathway at all yesterday? Okay, so I'll get into that, because then you can, I'll be able to illustrate how this actually works. All right, I'm going to use Marta as a prop. Okay, all right, so can I borrow your pen? I just pricked Marta. Can you hold up your hand? Which hand?
My right hand.
Okay, right hand. Can you feel the pain? Okay.
Let me go a little harder.
Can you feel it?
No, but I mean, I feel
Just
something.
sing, just play along, yeah.
You're very light.
Okay.
Light touch.
Okay. So, oh, that's great. Thank you for saying that, light touch. That's the buzzword, light touch, okay? All right, so I'm gonna use her arm as my prop, her hand, her right hand. So this is how the normal pain pathway works. There was a stimuli, there was a stimulus that happened, right? So, and then it released these chemicals, right? Cytokines got released into the area. It activated this nociceptor, okay? The nociceptor, these are these sensory neurons, right? Sensory neuron. We've all played telephone as a child, right? All of us,
Yeah.
right? I tell Marta a secret, and that message is being carried on exactly the way it is, and Marta then passes it on to Ari somewhere. So, yeah, exactly. So the stimulus, nociceptors come into play. The nociceptors, or this neuron, is going to carry this message to Ari, the first motor neuron, right? And then in that, actually, there are some chemicals that are also being released in that process. That first order neuron then takes it to Debbie, to the second order neuron. Okay? Second order neuron takes it to Athena, third order neuron. Okay, now watch. All right, we're gonna have to just do with this for a second because this is explaining the central pain sensitization, but imagine that there was a stimulus on this side. It came in, okay? It took it actually to the dorsal root ganglion, okay? That dorsal root ganglion. Oh, by the way, there are two types of fibers, okay? There are myelinated and unmyelinated, right? Alpha, delta, and just plain alpha. Oh, sorry, C fibers. So alpha, delta, it's really interesting, like how our body just knows all of this. Alpha, delta, the myelinated fibers, they are the sharp. I like, suppose like I pricked a needle in her, those fibers are gonna get activated. It's gonna be sharp, intense, short-lived pain. Okay, C fibers. It was that dull, achy, like, oh my God, I know something is there, but it's not there, but okay. That's that dull, unmyelinated fibers got activated. It's just prolonged pain or annoyance, right? That's that. So interestingly enough, it's those C fibers that get activated. This is where all of our sensations are, they get relayed in the dorsal root ganglion. So they come here. It relays to the first order neuron. Now, interestingly enough, first order neuron is on, when it takes that synapse, it's actually on the opposite side of the brain. It's not on the same side. That's why you transferred it to the other side, right? So it then, now this is an ascending pathway.
You mean the spinal cord?
Yeah, spinal cord. Did I say that?
Brain. You said brain.
Oh,
spinal
sorry.
cord.
Spinal cord, thank you. It goes up the spinal cord. It's ascending, okay? There's a substance called substance P that is released, right? That substance P is increasing the intensity of that pain. I'm just gonna we're gonna just get to the third order neuron. All right, so the third order neuron then it activates another neuron. Another pathway is being activated, which is the descending pathway. The descending pathway, the main function of that is, so ascending is taking the signal up to the brain, right? And then the descending is bringing it down that like you're not gonna have shooting pain. So it's basically trying to, neurochemicals, the neurotransmitters that are being released are trying to activate the brain to say that you're not gonna die, basically. That was a little bit of a stretch, but
They're modulating, yeah.
They're modulating.
Tempering it.
Yeah.
Yeah, good.
So what happens in this, okay, that was a normal pain pathway, right? But what's happening here is that the pathway is actually kind of just like hovering in this area. So it's not, the signal is not actually coming down. So when it's not coming down, they're feeling that they're having, and it's actually activating, it's based off of memory. So when it's not coming down, it just seems like that the patient is in intense pain because they had that initial spike of that substance P, right? So I'm actually gonna play this video. This is Dr. Jay Joshi, an anesthesiologist. He actually works in pain management. He explains this really well.
What's central sensitization? Well, to put it very simply, central sensitization is what happens when your brain is exposed to certain experiences or certain memories. It's life. It's being a human. That's what it is. You know, when you have a certain memory that forms, it becomes part of who you are. It becomes part of your experience. and your behavior changes as a result of that. It's not something that just happens esoterically. It's not something that happens randomly. This is something that happens organically. This is something that happens to the neurophysiology of your brain. It forms memory. Those circuits get hardwired on your little hard drive that's known as a brain. That's the same thing that happens with pain. When you have a chronic pain stimulus, usually one of the first things that happens is your brain says, hey, don't do that again. But what happens when that signal doesn't stop and the brain keeps saying, don't do that again, don't do that again, and the brain keeps amplifying the pain in order to make you stop doing that again? And that's really the pathogenesis of what central sensitization is. When that process keeps occurring and that problem keeps worsening, that's when we see these central sensitization disorders. Now,
Okay. So, all right. Okay. So that was central. That was the pathophysiology that's happening in fibromyalgia. Now, the treatments, the management, this is all integrated through the interviews that I conducted with not only with a Western clinical psychologist, pain psychologist, and also yoga therapists, a Western MD that practices not only integrative medicine, but also someone that just practices internal medicine. And also Harrison, again, our Bible, medical Bible, states that the management of fibromyalgia can be broken into two different modalities. So one would be the non-pharmacological treatment, and then the second would be the pharmacological. Non-pharmacological, they say aerobic exercise, water-based exercises, relaxation techniques. They don't really define relaxation techniques, but there has been studies that support mindful meditation. And believe it or not, yoga is written in our textbook. It says yoga, but they again have not defined what type of yoga. And there have been various studies of doing restorative yoga, and there have with relaxation and meditation to treat for fibromyalgia. And then there's been a study on Tai Chi because the movements are much slower because we want to slow that process down in these patients. So Tai Chi with meditation has also been found useful. Also, there's been core strength training, again, for the core, to build up the core. And then cognitive behavioral therapy. So when meeting with my clinical pain psychologist, her recommendation was she would treat the patient in an 8-week session, 8 to 12 depending on how severe the patient was. And it's very similar to the way we assess and treat or manage our patients in yoga therapy. The first session is completely just a clinical intake for 60 minutes. You could probably attest to that. The second, and therefore, they actually do group therapy versus one-on-one therapies like us. And she actually has them do a sleep log and a diet log to decipher the intervention that she's going to be, what type of intervention she's going to be using on these patients. Okay. And what I found really fascinating in her approach was that she has all of her patients, we all have cell phones, right? We all have cell phones, and the data that she collects is through the Fitbit that's already built in your Apple phone. So you don't necessarily need to have a Fitbit to figure out how much you're sleeping, when you're sleeping, how long are you sleeping, and what you're eating. Then in pharmacological, so we're going to treat them with antidepressants, and then we're going to, for the pain, because they also have neuropathic pain, so with anticonvulsants like gabapentin and pregabalin. Okay, So where is the pathophysiology for this in the yogic perspective? Okay. When our habit patterns become so ingrained that they alter our body chemistry, it is called addiction. When they become strong enough to alter our thinking process, it's called a samskara. We're all aware of this, right? So yoga philosophy believes in the samskaras, right? So samskaras, there has been speculation that these can also play a genetic component. Samskaras are nothing but habitual patterns that we have ingrained within our, and we've changed the neurophysiology within our brain, and we just talked about that. So fibromyalgia is nothing but this pattern of pain that we've created. That's what samskara is. We're creating that habitual pattern. So, but yoga philosophy believes that you can break through this. You can break through this. And how do you break through this? We're going to talk about that in just a minute. We also believe the pathophysiology also has to do with your dosha, which is your body constitution. Panchakosha model, we've already talked about both of these. And then the most fascinating thing is this gut microbiome theory. Oh my God, it gives me like goosebumps when I'm just thinking about this. Okay, did you know that there are 33 trillion, right? Yeah, Ari knows, she's on top of it. 33 trillion microbiotas living within our gut. And there is this concept of, in yoga philosophy, that has stated that these microbiomes, they actually have their own collective consciousness. So what fascinated me is that I always used to think collective consciousness is like somewhere up there, like you can't see it, like it's in our brain, it's in our head, and just like beyond that. While doing the research on this, no, quite honestly, it lives in our gut. Okay, so that was an awakening for me. That when it's in our gut, and we know the GBA axis, the gut-brain axis, how that relates to all of our emotions, and the brain relates to our gut, how we metabolize the food, eliminate the food, all of that comes into this gut microbiome theory. There are 8 more really important neurotransmitters that are released here. Okay, can you name off a few?
Serotonin, melatonin,
Dopamine.
GABA.
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 The drug. Yeah.
What else? Most important one. Norepinephrine. Not the one I was looking for.
Yeah.
What?
Did we already say dopamine?
Yeah, dopamine, serotonin, norepinephrine, GABA. Okay, ready? Acetylcholine, or either way I was taught is acetylcholine. Okay, acetylcholine is the most important neurotransmitter that is released in the gut over here. Why is this so important? Because this is what activates the parasympathetic nervous system. Okay, it helps rest and digest. I don't need to get into that, but it activates the parasympathetic nervous system, and it helps with decreasing our heart rate. It helps in metabolizing, which is increasing our digestion, and in elimination. And it plays such a crucial role in our cognition, okay, our memory, our emotions. Are you getting the picture with fibromyalgia here? Okay, all right. And it helps in concentration, obviously. Okay. Oh, another one that is released here that you guys missed is histamine. Histamine is, we've all been bit by a bee. If you haven't, please raise your hand at once in your lifetime. Really?
Just you wait.
Okay, like a big gigantic mosquito. I just got bit in Minnesota right here. Okay, this is what activates histamine. It's the inflammatory reaction. So whether it's a bee or it's a big mosquito, that it's going to cause inflammation, and histamine is going to come in.
Is it considered a neurotransmitter? I didn't know it was considered histamine.
No, it's a chemical. They consider it like as a hormone because it comes into the blood.
Oh yeah, I was going to say, I didn't think it was a neurotransmitter.
It has neurotransmitting functions.
Ah.
Yeah.
And then there's also like Sig A, Sig B, that's also it released in the gut, inflammatory response.
Yes.
Immune.
Yeah. And we said melatonin?
Mm-hmm.
Okay. Yeah. Those are the main ones that are released. So now you know the pathophysiology, how this is affecting fibromyalgia. Unless you have a doubt, let me move forward. All right. So also yoga philosophy talks about asana centered around grounding and core work in a patient like this. Okay. Going back to this gut microbiome theory. All right, so what's really interesting is that is the nexus at the Manipura chakra. Okay, so Manipura chakra, if you don't know, money means the jewel crown. Okay, money is like, if you break the word down, it is precious, like one of a kind jewel. Pura, like if that translates as city. Okay, so city of one of a kind jewel, and that's the nexus of the gut and the brain, or the brain and the gut, whatever way you want to call it, the GBA axis. That resides right here. So the Himalayan Institute, they're very big on accessing the Manipura chakra. But I want to just put this disclaimer out there that I just want everyone, I want to be clear in what I'm saying. It's not that we go directly to the Manipura chakra. You do have to do the preparatory work and then access the Manipura chakra. But if you can access the Manipura chakra, then you have been able to control your emotions. Whether it's fibromyalgia, whether it's chronic pain, whatever diagnosis it is, you then are, so remembering that very first quote of Swami Rama, right? Then that's basically what you're controlling. Okay, so we're gonna just do, has anyone done Agnisara in their life? 2 people, 3. All right. We're going to just do a little practicum, okay? It's always good to do more practice. And it's also believed when you can access Agnisara, because remember the GBA axis is all about our emotions, right? Your Agnisara, what that is doing, the Manipura chakra, what it's doing is it's helping digesting these emotions. So the samskaras then basically are getting eliminated because now you're able to digest and release or remove the negativity in our slang language that we say, remove the negativity. We're actually recorrecting the samskaras. Okay, so if you can just sit back in your chair once again, keeping your feet hip-width distance apart. feeling the floor underneath you. Sitting up nice and tall with your head, neck, and trunk in a straight alignment. Just take a few diaphragmatic breaths from your belly. And then on the next one, as you exhale, you're going to start engaging your inner thighs, your pelvic floor, your lower abdomen, your mid-abdomen, your upper abdomen. And then as you inhale, you relax in that order: upper abdomen, mid-abdomen, lower abdomen, pelvic floor, inner thighs. Exhaling, inhaling. Exhaling, inner thighs, pelvic floor, lower abdomen, mid-abdomen, upper abdomen, and relaxing as you inhale, upper, mid, lower, pelvic floor, and inner thighs. Take 2 more at your own pace. And then as you're ready, gently open your eyes. Is there anything that you felt different? Thank you. What did you feel?
I felt a little high.
Okay.
A little stoned. Felt
Okay.
really good.
Okay.
Yeah. And really, like I was in the ocean, like kind of cool in the ocean.
Okay. Anyone else?
It's different from how I had learned it,
Yeah.
and it was more calming because I had learned it as a forceful, more almost. Yeah, I learned it on the exhale to contract in that wave on and off, which is almost anxiety producing because you're holding that exhale out, so it feels more accessible.
Oh, good.
Yeah, I've had a similar experience.
Good.
It's a different way in.
Good. Good. Okay. So, sticking to the schedule then, what is the management of fibromyalgia through the yogic lens? At the Himalayan Institute, Swami Rama believes that we're accessing the patient as a whole, in a holistic manner. So it's not that we're just doing natural energetic flows, which is the term that is used over there is joints and glands. But for Westerners' eyes, it's known as natural energetic flow. Also similar to Tai Chi, if you think about it. Okay? Grounding asanas. But before all of that, before we even get to the exercise, we have to do an assessment on the patient that we all did, right? We're going to look at their lifestyle. We're going to figure out what their diet is like. Are they sleeping enough? Are they pooping enough? I mean, are they eliminating? Are they, how is their breath? First, we got to train them on the breath. Because that second client that I had was a reverse chest breather. I couldn't get her to breathe correctly. We tried the sandbag. We tried the crocodile. It wasn't working. So even before all of that, if you remember the Kosha model, the first is the Annamaya, the physical appearance. I mean, the external, the skeleton, right? Her structural alignment was not correct. She was misaligned. She had an anterior neck carriage. She had a pelvic tilt and walked with rounded shoulders. So and then she was reverse breathing. Laying her on the floor to do sandbag and crocodile after the 4th session, I was just like, I was getting frustrated that why am I not improving with her? But yet she kept showing up. She was on the dot every time. It dawned on me to go back to the Kosha model to start there first on the external. I had her for 50 minutes align herself against the door, push her shoulders back, erect her spine, and then walk all throughout the room. She was walking like a zombie, like a robot, but it didn't matter because she was in alignment at that point. And when she was in alignment, then that's when I started accessing her breath. Okay. I was frustrated with, like, when I was working with the second client on getting her to sleep. I tried to give her a sleep schedule. I try to get to bed at 11:30, trying to weed in her to get her to go to bed half an hour early every week. It just was not working. That's something that the clinical psychologist said to me as well. That's how they would treat that patient. I tried working with her on the diet. Was not working. Well, what did work was that she started eating regularly, but what she ate didn't. I mean, that was the next step. I couldn't give her too much all at once. And we did some of this, the joints and glands. Standing, sitting in a chair, and then the relaxation. So the Himalayan Institute is really big on the 61-point relaxation technique. And all it is, it's just bringing the awareness, the mind, to each different points within your body. And you inhale, exhale in those particular points to relax the body. Again, that's why it's called systematic relaxation. And then we move on to meditation. So when I was managing these two patients, I was looking at them as a whole, not looking at them as I'm only going to work on this or something else, you know. And then Swami Rama also says that after you've done all of this, the meditation is the next step. So meditation, the only meditation that I have ever given is Soham and Om. And that's, again, to get them to breathe, to activate their breathing. And then I move, as you've mastered this, then you automatically start observing your mental and emotional habits, so then you start cleansing at that level, and then the self-assessment comes in. But most of the patients that both the 3 clients that I worked with, this is as far as they got, up to the relaxation. Okay, so the integrative approach, right? What does integrative medicine actually even mean? So there are some thoughts that it's complementary medicine. I don't believe it's complementary. They go hand in hand. That's what integrative is, right? When you ask a Western physician what does integrative medicine to them mean, they will say it's complementary, alternative. These are in quotations the buzzwords that they use. This picture represents if we were to treat the patient from one perspective. These are the roots that are drying up, that are dying. Even though the leaves are look healthy, but eventually this patient or this tree is going to erode because the roots are eroding. So the integrative approach would be treat the patient through pharmaceuticals. treat the patient through cognitive behavioral therapy. It's not just one. It's one and plus another, right? So it's pharmaceuticals or yoga therapy or hypnotherapy or acupuncture, massage therapy, doesn't matter. They are working synergistically with one another. And because I am trained in Western medicine and now have learned about yoga therapy, my soft corner is always to do both of these together. Although the integrative medicine physician that I had interviewed, she was not aware of yoga therapy. She was just aware of acupuncture, massage therapy, and then would treat the patient based on supplements. Would provide supplements and mindful meditation. Okay, so the last slide here represents, we want to look at the patient again from a holistic perspective, the integrative perspective. When all modalities of treatment are working together, then this tree, this patient, this human being is flourishing to their full potential. We improve the quality of life all around. The roots are not dying. And there you have it.